My presentation today is the multimodality approach to inflammatory breast disorders. The current breast imaging modalities play a vital role in supporting clinicians in the primary diagnosis, in treatment selection, in the treatment progress and monitoring of the different breast diseases. And actually, when using the different imaging modalities, breast imaging radiologists must be able to fulfill two essential jobs. They must be able to select the most suitable imaging modality for every clinical scenario, and in the same time, they must be able to provide competent interpretation and reporting. And now that we have more and more imaging modalities in hand, it has become a real challenge to choose which is the most appropriate imaging modality for each clinical scenario. And it has become a challenge too to choose which of these modalities will yield the anticipated information most accurately while causing the least amount of patient compromise. And I think to do this, we should be aware or acquainted to the limitations of these imaging modalities, even far before we know their advantages. And from this perspective, I'm going to discuss with you today the inflammatory breast disorders. As I said at the beginning as Muller said at the beginning in the introduction, please, you should have a paper and a pen with you. I'll show you 8 cases at the beginning of my lecture, and we'll go back to these 8 cases at the end of the lecture. The first case is a 35-year-old female presenting with a palpable left breast mass and resistant mastitis. She has a global asymmetry of the left breast, and when she performed an ultrasound examination, there was a diffuse inflammatory reaction with indeterminate axillary lymph nodes showing cortical thickening, but preserving their oblong shape and part of the fatty hilum. This was her MRI examination, and on MRI, we saw intense regional non-mass enhancement with overlying skin thickening. And when we plotted the time signal intensity curve, there was a washout curve. Going back to the T2 weighted images, we found that the corresponding area showed a bright signal, a bright T2 signal. And the challenge in this case, is this lesion benign or malignant? And what do you think about the quality of the left breast mammogram? Was it a good mammogram, or do you think it was of a very low quality? And was adding ultrasound enough or no? And did MRI help in making a diagnosis or no? Now we move to the second case. She's a 25-year-old lactating female presenting with a markedly swollen, hot and tender breast. She came for an ultrasound examination which revealed inflammatory changes of the breast with globular axillary lymph nodes. And the challenge in this case, are these inflammatory changes benign or malignant? And what should we recommend in this case, a follow-up study or a direct biopsy? Case number 3 is a lactating patient with right breast inflammatory changes that were resistant to antibiotic therapy. This was her mammogram. She had a global asymmetry of the right breast with pathological axillary lymph nodes, and she had indeterminate microcalcifications in the upper outer quadrant of the right breast. Based on these findings, she was assigned a BI-RADS 4C based on the mammogram. She performed a 3D digital tomosynthesis. This was the tomosynthesis images, and this was her ultrasound, which revealed multiple irregular hypoechoic mass lesions of query nature. She was sent for an MRI examination, and these were the contrast subtraction and dynamic MRI images, and these were the T2 and the STIR images. Now, the challenge in this case, are these lesions benign or malignant? Do you think that 3D digital tomosynthesis was a good choice? And was MRI a good choice or not? Case number 4 is a 23-year-old with progressive lactational mastitis. She was sent for an ultrasound examination, which revealed non-specific ultrasound picture, but there was an increased overall left breast vascularity. When we looked at her axillary lymph nodes, they were globular in shape with a lost fatty hilum. They looked pathological. And she was sent for an MRI examination, which showed diffuse regional non-mass enhancement in the left breast with overlying skin thickening. And this was the corresponding T2 weighted image, which showed interstitial edema together with a corresponding dark T2 signal to the same area showing contrast uptake. And the challenge in this case, is this lesion benign or malignant? And what do you think we performed an MRI study? Why do you think we performed an MRI study? This is case number 5. She is a 28-year-old presenting with palpable right breast mass associated with inflammatory signs. This was her ultrasound examination, which revealed multiple hypoechoic mass lesions with indeterminate axillary lymph nodes. And this was her mammogram, which showed a focal asymmetry of the right upper outer quadrant. She was immediately sent for an MRI examination because she was thought that she had a malignant mass lesion, and the MRI showed an area, a segmental area, which showed a hypointense signal on both the STIR and the T2 weighted image. And this was a diffusion weighted imaging, which showed partial diffusion restriction. And when we injected the contrast, there was clumped segmental non-mass enhancement along the same area. A biopsy was performed twice, and it came back that there was no malignant cells in the biopsy specimens. Her clinician was still worried, and he sent her back again to perform a PET mammography. And on the PET mammography, there was a heterogeneous radiotracer uptake with a PUV max of 5.6 and lesion to background activity 10.9. And these values are too high, and they usually indicate malignant breast lesions. So the challenge in this case, is it benign again or malignant? And was immediate MRI a good choice or no? Did MRI add anything or no? And did PEM add anything or no? Case 5 and 6 are 6 and 7 are two similar cases. The first one, she had resistant mastitis, and on her mammogram, she had a global asymmetry. This is the contrast mammogram of the same patient showing a corresponding non-mass heterogeneous enhancement. And the second case, she had a left breast resistant mastitis. Again, she had a retroareolar asymmetry, and on the contrast mammogram, she had heterogeneous non-mass enhancement corresponding to the same area. So which do you think of these lesions is benign and which is malignant? Case 8, or number 8, is actually 3 different cases. On the recombined images, they show a rim enhancement pattern. And the question here is which of these lesions is benign and which is malignant? And now I'll start my lecture. And we'll go back to these cases at the end of the lecture. The inflammatory breast disorders, or what we commonly call mastitis, is a frequently encountered clinical complaint. The term mastitis is often used synonymous with breast infection, but strictly speaking, mastitis is inflammation of the breast irrespective of the cause. Inflammatory breast disorders encompass a wide variety of breast lesions with different management protocols, starting from the simple mastitis, which is treated by simple antibiotics and hot fomentations, going down to the inflammatory breast carcinoma, which is treated with neoadjuvant chemotherapy and mastectomy. And to reach an accurate diagnosis often entails repeated unnecessary biopsies. And actually, my lecture today is based on some research work that I performed with some colleagues in the radiology department in Asr Laini. We published it in 2009, And in this publication, we proposed a new classification for mastitis, where we classified inflammatory breast lesions into infectious mastitis, and these include the simple lactational mastitis, a mastitis which becomes complicated with an abscess cavity, and then mastitis which occurs secondary to a specific infectious organism like the TB or the Pseudomonas. The second type of mastitis is the non-infectious mastitis, and it includes a long list of lesions, and it usually occurs either due to chemical irritation or due to an autoimmune reaction to the breast. And the third type, and which is the most serious type of mastitis, is the malignant or the malignant mastitis, and this includes the inflammatory breast carcinoma and the malignant breast abscess. Pain is usually the first signal of tissue damage or inflammation, and it usually has an emotional quality together with a sensed body location. And that means that any patient presenting with mastitis, she will feel bad, and in the same time, her breast hurts. And it is actually because of this pain that most of the patients who complain of mastitis seek early medical advice. And they are usually given a short course of antibiotics together with hot fomentation, and complete resolution is usually the rule. Then why is the patient sent for imaging? She is sent for imaging either to confirm the diagnosis, to monitor treatment, to exclude complications, to exclude unusual forms of infection, to exclude non-infectious mastitis, to exclude the presence of inflammatory breast carcinoma, and lastly, to guide for different interventional procedures. And actually, in this lecture, we will go down this pyramid step by step in order to reach a competent diagnosis whenever we encounter a case of mastitis. And we'll start by the first step, and that is how to confirm the diagnosis of mastitis. We should always remember that a patient with mastitis is usually a young, lactating female. She has a painful breast, and she has an added increased density to the already inherent density because of her age. So we expect that on a mammogram, we find a non-specific picture for mastitis. We might find poorly marginated areas of increased densities or non-diffuse edema, non-specific diffuse edema pattern of the breast. We might find skin thickening and enlarged axillary lymph nodes. And we can imagine that this is how a lactating breast looks on a mammogram. If we add mastitis to this lactating breast, I think we will see nothing in the mammogram. On the ultrasound examination, on the other hand, we see a specific appearance for mastitis. And on ultrasound, also, we can accurately identify the size, the site, and the extent of mastitis, and we can pick up mastitis in its early stages. We have specific signs to prove that this is a benign inflammatory breast disorder. They usually include the edematous echogenic fat lobules, which are delineated by interstitial edema lines. Sometimes it's more than interstitial edema. It is like ill-defined collections, and sometimes these ill-defined collections proceed to actual abscess cavities. And when we look at the axillary lymph nodes, we find that we find reactionary nodes, and they usually retain their fatty hilum, although they have a diffusely thickened cortex. And in the same time, we do not find any malignant mass lesions, and we do not find dilated subdermal lymphatics. And the subdermal lymphatic is this very fine layer seen here, separating the skin from the breast parenchyma, and it is usually a potentially collapsed space. It only becomes dilated when there is a lymphatic obstruction. But unfortunately, things are not always straightforward as they appear to be. Sometimes we have atypical ultrasound presentations, like we have a parenchyma with an increased vascularity. We might have abscess cavities, which might look exactly like solid mass lesions. And we might have axillary lymph nodes that look exactly like the pathological infiltrated malignant nodes. And in these cases, we fall in the dilemma whether this is a benign or a malignant inflammatory condition, and in these cases only should we proceed to further imaging modalities. On MRI, if we perform MRI early in the course of mastitis, we will again have a non-specific appearance because we will have, for example, a segmental hypointense area on the T2 weighted image, which is usually associated with edema, which is seen more on the STIR images. If we inject contrast, we will have segmental non-mass enhancement, and this appearance typically fits with a malignant diagnosis. But if MRI is performed late in the course of mastitis, we might find actual abscess cavities within this area, and this might help us to confirm that this is an infectious mastitis and not a malignant form of mastitis. The first case is a 30-year-old female patient with left breast chronic inflammatory changes. She had a heterogeneous dense breast parenchyma, and the left breast parenchyma appeared distorted. This was her contrast mammogram, and it revealed retroareolar enhancing nodules and focal non-mass enhancement, and she was assigned a BI-RADS for referring to the appearance of the lesion on the contrast mammogram. Actually, we performed a biopsy, and the biopsy came back with mastitis. The patient was followed up, and the condition completely resolved. So to confirm the diagnosis of mastitis, we have to remember that we have a painful, dense, and swollen breast. So we will say yes, go for an ultrasound examination, and no, do not perform a mammogram or any sort of contrast imaging early in the course of mastitis. We'll move another step downwards, and that is the patient was diagnosed, she's receiving treatment, and we have to monitor this treatment. All mastitis patients should be asked to come for a short-term follow-up study after a course of antibiotics and hot fomentations to ensure complete resolution. And this was one of the cases that I showed you at the beginning. She had inflammatory signs, edematous, echogenic fat, interstitial edema lines, and maybe a little collections and skin thickening. And her lymph nodes were not good looking. It looked as if they were pathological. But we always have to remember that lymph nodes are usually not good looking in any lactating, normal lactating woman. So if she has superadded mastitis, we would expect that maybe the lymph nodes is due to the superadded mastitis due to the lactational status of the patient. She was given antibiotics and hot fomentations, and she was asked to come for a follow-up. On her first follow-up, the condition markedly improved, and on a second follow-up, she returned to a normal. There was complete resolution of the mastitis, and even her axillary lymph nodes returned to their original appearance with a preserved fatty hilum. And this was a case of simple lactational mastitis. And so based on a short-term follow-up study, we will again say, yes, go for an ultrasound examination, and no, do not perform mammography and contrast imaging based on a short-term follow-up. As we've just said, that complete resolution is usually the rule. But what if mastitis does not resolve? If mastitis does not resolve, we should expect that there might be an underlying complication. It might be due to an unusual form of infection, or it might not be infective from the start. It is non-infective mastitis. It might be due to a malignant inflammatory carcinoma of the breast. And in this case, we'll move another step downwards and try to, we have a case of mastitis with non-resolving mastitis, and we want to exclude underlying complications. This was a female patient with the right breast chronic inflammatory changes, and then she developed a palpable retroareolar mass lesion. Based on her mammogram, we can easily give her a BI-RADS 4 because this lesion appeared to be speculated. But with a single look on the ultrasound examination, we can see that it is simply an abscess cavity with floating internal particles. Another complication which might occur with mastitis are the draining sinus tracts. This was a lactating female patient with resistant inflammatory changes of the left breast. This was her mammogram. She had a focal asymmetry of the left breast. And this was the contrast mammography, and it showed a mass lesion in the upper outer quadrant of the left breast. It was oval in shape. It showed rim enhancement with anterior intraductal extension. I think anybody who sees this description of the lesion will definitely say that this is a malignant breast lesion. While looking on the MRI of the same patient, we will find, yes, the lesion showed rim enhancement, but going back to the T2 weighted image, what's inside this rim is simply fluid, and it was not a solid mass lesion. And this was simply an abscess cavity in a case of granulomatous mastitis. So to exclude underlying complications, this time we will add to the ultrasound the MRI for selected, and not all patients, for selected patients. And again, we will say no, do not go for a mammogram or a contrast mammography. We will now move another step down to exclude unusual forms of infection. And we have a long list of unusual forms of infection. And actually, during my practice, I have only encountered the atypical organisms, which include the Pseudomonas and the Proteus infection and the Mycobacterium infections. The problem with these organisms is that they need specific treatment. They will never respond to the normal antibiotics that are usually given to the patients. This was one example. She was a 45-year-old female patient with long-standing indurated right breast with discharging sinuses, which was not responding to any form of antibiotic. This was her mammogram, and it revealed multiple areas of parenchymal distortions with overlying skin traction. And these were her axillary lymph nodes. And I think based on the mammogram, we can easily give her a BI-RADS 4. While looking on the ultrasound, there were multiple abscess cavities with discharging sinuses through the skin. A biopsy was taken, and this was a case of tuberculous mastitis. This was another case, one of the cases that I showed you at the beginning of my lecture. She's a young female. This is a bad quality mammogram because the patient was young. She could not withstand compression with superadded mastitis. This was her MRI examination, and there was regional non-mass enhancement and type 3 curve. But looking back at the T2 signal of the same area, it was an intermediate to bright signal, and usually this signal indicates more of a benign than a malignant pathology. And actually, a biopsy was taken, and it was simply Pseudomonas infection of the breast. And later in the course of her disease, she began to develop actual abscess cavities within the same area seen on the STAIR and on the T2 weighted images. So to exclude unusual forms of infection, again, we will say yes for ultrasound and MRI, and up till now, no for the mammogram and for the contrast mammography. If you do not find unusual infections, we might think that this is an inflammatory process which is not resulting from an infective organism from the start. And we have a long list of lesions which are included in this group. I will only discuss the granulomatous mastitis and the periductal mastitis. And actually, these lesions altogether, they occur either due to chemical irritation of the breast or due to a secondary autoimmune reaction. The periductal mastitis or ductictasia affects major ducts and is poorly understood. A variety of different terms have been used for this condition, and these probably reflect different stages of one disease process. Periductal mastitis appear to be the primary condition, with ductictasia being the outcome. The process starts, as we said, with an inflammatory process that leads to destruction of the elastic network of the ducts, ending up with ductictasia and periductal fibrosis. If these ducts become filled with calcified secretions and they become invaded with lymphocytes, plasma cells, and histiocytes, then we get what is known as the plasma cell mastitis. This is how the story begins. These are dilated ducts with retained secretions surrounded by an inflammatory reaction, or what we call periductal mastitis. When this inflammatory process resolves, it leaves the patient with dilated ducts with retained secretions within the ducts, and the process keeps repeating itself times and times. This is a case of a typical appearance of the periductal mastitis with the calcifications, rod-like and lucent-centered calcification, but because the calcification was associated with the focal asymmetry of the left breast, we performed the contrast mammogram in this case, and it was informative in this case to exclude any underlying malignant pathology. The question is, when should we proceed to advanced imaging in cases of periductal mastitis? We should proceed whenever we have non-resolution or whenever we suspect underlying malignant pathology. This is a 36-year-old female with resistant left breast inflammatory changes. This was her mammogram in January 2020. She had a retroareolar mass lesion, which on ultrasound turned out to be an infected cyst, or it can be considered an abscess cavity. She did aspiration cytology of this abscess cavity, and she came in January 2021 with this appearance. She had a developing asymmetry of the left breast, and this was the ultrasound appearance. There were underlying dilated ducts with retained secretions. And on MRI, again, she had duct ectasia with multiple abscess cavities surrounding the dilated ducts. We did a biopsy, and the biopsy came back with a periductal mastitis and multiple abscess cavities. This was how she looked in January 2021. She was given treatment and she was asked to come up for a follow-up after 5 months. And she came after in May 2021, and this is how her breast appeared. And look at the dilated ducts with the retained secretions. Now she has dilated ducts, duct ectasia with minimal retained secretions with no periductal inflammatory reaction. And this is how her MRI appeared in January, and in May, the periductal edema or inflammatory changes resolved. Most of the abscess cavities seen on the T2 weighted images were resolved, with a few only chronic abscess cavities or secondary fat necrosis seen on the subtraction image in May 2011. The second form is the idiopathic granulomatous mastitis, and it usually occurs either due to chemical irritation, to trauma, or to viral infection. The etiology is unknown in granulomatous mastitis. But whatever the etiology is, the end result is that there is damage to the ductal epithelium, and this stimulates a localized autoimmune response, and it enhances lymphocyte and macrophage migration to the breast. The patients usually present with a picture which is typically like the malignant breast lesions with palpable axillary lymph nodes, and sometimes she has discharging signs. On a mammogram, the picture also mimics cancer. She might present with a mass lesion with focal or global asymmetry, and she might have skin thickening, pathological lymph nodes with plus or minus calcifications. On ultrasound, early in the course of the disease, she has a simple picture of mastitis with echogenic fat, interstitial edema lines, and skin thickening. There is sometimes, as the disease progresses, there is an altered parenchyma with increased vascularity, and when we do MRI, we might find masses or non-mass enhancement. It is common to find multiple well-formed abscess cavities, and these cavities usually have a tendency to discharge, to form the sinus tracts discharging through the skin. And to exclude non-infectious forms of mastitis because they mimic breast cancer, we will say yes for an ultrasound, for a mammogram, for MRI, and no for contrast mammography in the acute inflammatory stages. But if the condition is proved and if the patient is chronic, we can perform a contrast mammography just to monitor treatment. And now we come to the most serious form of mastitis, and that is to exclude inflammatory carcinoma of the breast. Malignant mastitis of the breast includes the inflammatory breast carcinoma and the malignant breast abscess. Inflammatory breast carcinoma, in a certain percentage of women diagnosed with inflammatory breast carcinoma, they were originally diagnosed as simple mastitis. And most physicians will prescribe antibiotics to rule out mastitis. If after a week the symptoms do not dissipate, a biopsy should be performed. Inflammatory breast carcinoma usually presents with acute fulminant inflammatory symptoms, and this is mainly attributed to the fact that inflammatory breast carcinoma grows in nests or sheets rather than confined masses. The cancer cells clog the lymphatic system just below the skin, giving a picture similar to mastitis. On a mammogram, we usually see a diffuse edema pattern with increased breast density, skin thickening, and coarsened trabeculae. On ultrasound, we have specific signs which favor a malignant rather than a benign form of mastitis. Yes, again, we see the echogenic edematous fat lobules, which are surrounded with interstitial edema lines. They are in many cases associated with dilatation of the subdermal lymphatic layer and with overlying skin thickening, which might proceed 4 millimeter, and it sometimes reaches over 1 centimeter. If we look in the breast, in many cases, we can find associated malignant mass lesions, and the axillary lymph nodes are pathologically looking. They are globular with eccentric or muffled hyla and with increased cortical thickness. And in the same time, we do not see the collections that we saw in the infectious mastitis, and we do not find abscess cavities with the malignant forms of mastitis. In a study that we performed on 90 cases, we studied how can MRI differentiate between the signs of benign and malignant mastitis. The morphology and kinematics of enhancing lesions were insignificant. What was significant was the T2 signal, because it was intermediate to bright in the benign mastitis and dark in the malignant forms of mastitis. If we find collection or abscess cavities, this favors a benign pathology, while if we find associated mass lesions and pathological lymph nodes, this favors a malignant form of mastitis. This is a case of a diffuse edema pattern of the left breast. There is increased density, skin thickening, coarse intrabically associated with pathological axillary nodes. This is how her breast appeared on ultrasound, with skin thickening, interstitial edema, dilated subdermal lymphatic, and echogenic fat lobules. And this was how the lymph nodes appeared. They were enlarged, typically pathological lymph nodes. And this was a case of an inflammatory breast carcinoma. This was another case with a diffuse edema pattern of the right breast. And on ultrasound, again, she had a picture of inflammation, but this time it was associated with underlying mass lesions and with pathological axillary lymph nodes. And usually in these cases, they are given neoadjuvant chemotherapy before they perform a mastectomy. And we usually follow up these cases using contrast mammography. It's much easier than performing an MRI. And this was her contrast mammogram. It showed multiple underlying mass lesions underlying the diffuse inflammatory changes. And again, this was her pre-neoadjuvant mammography, and this was the post-neoadjuvant mammography. And we can never say, based on the mammography alone, whether there was good response or no. But looking at the contrast mammography, this was the pre-neoadjuvant films, and these were the post-neoadjuvant films. We can see that there is near total radiological response of the lesion. This is another 32-year-old female with inflammatory right breast symptoms and a large palpable mass lesion. She had an edematous right breast with an indistinct large mass lesion. This was her contrast mammogram. It revealed an underlying thick, irregular rim-enhancing lesion, and a biopsy was taken and the aspiration cytology, and they both revealed that there was pus together with malignant cells within the lesion. This was her CT examination, and unfortunately, this patient, she was metastatic from the start, and this was a malignant breast abscess. And so to exclude malignant mastitis, advanced imaging modalities are usually needed for the diagnosis and for the follow-up of these patients during their treatment. And it is only in this case will I say yes for all imaging modalities. And lastly, we come for guiding for different interventional procedures. And we should proceed for a biopsy whenever we have a mastitis, which is resistant to antibiotic treatment, and with suspicious signs, with mastitis with suspicious signs from the start. We can perform an aspiration cytology, a true cut biopsy. Sometimes we need to do a skin punch biopsy and lymph node biopsy, especially in cases of inflammatory breast carcinoma. And to put up a diagnostic scheme, whenever we encounter a case of mastitis, the first step, we should perform an ultrasound examination. This is the best modality. We look for ultrasounds of inflammation. And when we diagnose mastitis, we start looking for other signs which help us to differentiate whether this is a benign or a malignant mastitis. If we find no other signs, we give a patient antibiotics and hot fomentation and tell her to come back for a follow-up examination after 10 days. A complete resolution is the rule in cases of simple mastitis. If we find incomplete resolution, we might need to perform an MRI or any contrast imaging, or to perform ultrasound-guided biopsy just to exclude the specific form of mastitis, the non-infectious, and the inflammatory breast carcinoma. If we look for other signs and then we find associated abscess cavities or sinus tract or infected cysts, we might need to perform an MRI examination, and we should drain this abscess cavity and do a follow-up ultrasound study to ensure that the patient reaches complete resolution. While if from the start we find pathological lymph nodes or mass lesions within the breast, we should proceed directly to contrast imaging and ultrasound-guided biopsy. So in conclusion, ultrasound still remains the first-line modality in the assessment of inflammatory breast lesions. Mammography is non-informative as it gives a non-specific picture. In addition, the patients can't withstand adequate compression, which further hinders adequate interpretation. MRI, although a useful adjunct to ultrasound, should not be performed early in the course of inflammation and should be only reserved to specific situations. Whenever we have mastitis, which is resistant to medical therapy, or to confirm or exclude underlying malignant lesions, whenever we cannot find a biopsy target, to delineate precise disease extent, and to monitor response to chemotherapy in malignant mastitis. Contrast mammography can be deceiving when used to characterize inflammatory breast lesions and should be only reserved for diagnosed cases to assess the extent of underlying disease and to monitor chemotherapy, while 3D digital tomosynthesis should not be incorporated in the diagnostic workup of inflammatory breast lesions. Now we go back to the cases. Maybe some of them I showed you in my lecture. This is the first case with the global asymmetry and diffuse inflammatory changes of the right breast. This was her MRI, and we said that she showed a bright signal, and by now we understand that this bright signal usually takes us to a more benign than a malignant pathology. And actually late in the course of the disease, this bright signal was the signal of the phlegmons, which turned into actual abscess cavities within the same area. So the challenge in this case, is this benign or malignant? We could only say it is benign based on the Brighty2 signal, which was confirmed with the biopsy. What do we think about the quality of the mammogram? Definitely is a very poor quality. The patient is young and she has a mastitis, and the compression is painful. Was adding ultrasound enough? It was good for follow-up, but it was not conclusive in the diagnosis in this case. And actually MRI made us more content with the pathology report of a benign inflammatory mastitis, and this was a case of atypical organism due to Pseudomonas infection. This was the second case with mastitis, and by now we can understand that this might be a normal appearance of the axillary nodes of a patient, of a lactating patient with superadded mastitis. We can give her a chance of an antibiotic therapy and see if she doesn't improve within 1 week, we should proceed to biopsy. But for this current situation, we should follow her up. And actually on follow-up, she responded, and even her lymph nodes returned to their original appearance. So the challenges in this case, are these inflammatory changes benign or malignant? We cannot say based on the first examination. We can only confirm it is benign based on the follow-up ultrasound examination. And what should we recommend? As we said, we should give her a short course of antibiotics. Non-resolution after 10 days is an indication for biopsy. And this was a case of benign lactational mastitis. This was the third case who was assigned a BI-RADS 4C, and this was her tomosynthesis. And this was the ultrasound appearance, and this was the MRI. And looking on the MRI, she had rim-enhancing lesions. Just looking at the T2 and the STIR, and we see that what's inside the rim is bright fluid signal. It's the diagnostic that these are multiple abscess cavities and they are not malignant lesion. So are these lesions benign or malignant? We can say this based on the MRI appearance. Tomosynthesis added nothing. It was a bad choice to do a tomosynthesis in a patient with a painful breast. We have to keep her breast compressed for a long time. It's not a good choice. And did MRI add anything? Yes, MRI was conclusive for multiple abscess cavities. And she was actually biopsied, and it was a case of a complicated mastitis abscess with abscess cavities. This is the 23-year-old female. She had this appearance in her breast, and she had pathological axillary lymph nodes. Actually, when she came to us, she had already received multiple courses of antibiotic therapies, and that's why we sent her directly to an MRI. Before sending her, we thought she had we thought it will turn up to be a granulomatous mastitis, but unfortunately, when we performed the MRI and we saw this enhancing lesion, and it was not because of the enhancement, but because of the dark T2 signal seen on the T2 weighted images. And based on this, we said, no, most probably this is a malignant lesion. And actually, this was a locally advanced cancer. And locally advanced carcinomas, they usually receive neoadjuvant therapy before being operated upon, because a surgeon will never operate on such an edematous breast. So she received her neoadjuvant course, and she came back for a follow-up MRI examination to assess for the response. Actually, there was near total response with residual mild thick skin thickening, and the lymph nodes totally resolved. But this doesn't mean that this patient will perform conservative surgery. She was a candidate for mastectomy from the start because of this diffuse edema pattern, and any inflammatory breast carcinoma ends up with a mastectomy and not conservative surgery. This was the case in which she had multiple hypoechoic lesions with indeterminate nodes. She had an asymmetry in the left breast. She was sent directly for the MRI, and actually early MRI was completely deceiving. Looking at this picture with a segmental, heterogeneous, or clumped numb mass enhancement, we can definitely say that this lesion is malignant. And you remember that she was biopsied twice because her clinician was never satisfied with the diagnosis based on how the lesion looked on the MRI. And she was sent for the third biopsy, but actually I refused to perform this, to do a third biopsy. And he insisted that he needs a PEM or a PET mammography. And actually it was more deceiving than the MRI because it gave us values which were just similar to a malignant breast lesion. When she came for the third time, I told them, please perform a non-enhanced MRI. I just need to see the T2 weighted image and the stare of the same patient. And by this time, she actually had well-formed abscess cavities and ill-defined collections within her breast. And as we said, a bright signal on the T2 on the stare with multiple abscess cavities points or confirms that this is an infectious and not a malignant mastitis. We did a second look ultrasound at this stage, and actually there were multiple abscess cavities within her breast, and she was followed up, and by time the abscess cavities tried to resolve by repeated aspirations and antibiotic therapy. So the challenge in this case, is this benign or malignant? It is benign, but it was only based on the follow-up and confirmed by the biopsy. Was an immediate MRI was not a good choice. A delayed MRI showed that this was an inflammatory, normal, simple, benign inflammatory action, even without the contrast injection. And actually, PEM did not add anything. It added to a more dilemma of diagnosis. These are the two similar cases, and actually they looked similar. They showed similar contrast pattern, and one of them, the first, was an invasive duct carcinoma, while the second was granulomatous mastitis. And based on this, I usually tell them that please, whenever you are encountered with a patient coming with acute inflammatory signs, and she is still not diagnosed, please do not perform a contrast mammography because it will not solve the problem. We will never be able to differentiate between malignant and benign form of mastitis based on a contrast mammography in the acute stages. But if you have the patient diagnosed and you just want her to monitor her treatment, it's okay. You can perform a contrast mammogram just to see, because it is much easier than to monitor the treatment using MRI. Number 8, we had 3 cases with REM enhancement. The first case was an infected operative bed seroma. The second case was an invasive duct carcinoma grade 2. And the third case was an abscess cavity. And I think based on the MRI, on the contrast mammography alone, we can never differentiate between the 3 cases. And in these cases, usually we have to couple what we see in the contrast mammography with what we see on the ultrasound to be able to diagnose the lesions. And thank you. By this, I finished.